Hello and good afternoon. Thanks for joining us again for the will we be the last ones to know about an early 2022 Omicron Lockdown webinar. So in case you haven't met, I haven't had the opportunity to meet you personally, you do have the trio experience today. My name is Holly Foxworth. I'm one of the registered nurses here. I'm also the marketing manager for content. And I brought along two of the familiar faces, our CMO duo. We have the CMO, also known as Chief Medical Officer, Dr. Scott Cherry, and CMO Chief Marketing Officer, Dara Wheeler. And our goal really is to first say that we get it. We understand this has been quite the week. There's a lot of news that's moving, a lot of headlines. Unfortunately, it doesn't look like it's going to get any better in the immediate future. But what we can do is kind of provide some clarity around what's going on with the surge of all of these cases, what's going on with variants, what to expect, and most importantly, what it is that you can do to effectively manage this, especially in the workplace. So before I have the panel introduce themselves, I will just kind of point out two quick things because I know we have a lot to cover. So the first is that I see we have some questions that are coming in. If you haven't located how to submit a question yet, that is at the top of your screen on the right-hand side. So you just type in your question. Some of those that are submitted, we will kind of incorporate into what's going on, what the discussion is. Others we will pick up in the town hall section. So there's no such thing as a silly question. We're all here for the same purpose, and that is to take care of ourselves and take care of each other. So anything that you have to say, please feel free to type that in, and we'll make sure that we can get you some answers. The second one is that at the bottom of the screen, also on the right-hand side, is the resource section. And so if you have questions about what's going on, about needing some information about COVID, we've also added in the COVID risk calculator, which actually is really interesting. I won't go into a lot of the details, but you can put in your individual demographics, and that's specific to your employee population, and really kind of keep a close eye on what's going on with your risk level there for your organization. So you might check that out as well, in addition to the white paper and the copy of today's slide deck, if you need it. So I'm going to go ahead and stop there, but let's go ahead and introduce the panel, then we'll jump in. Dr. Cherry, you want to go first?
Sure. Hi, my name is Scott Cherry. I'm Axiom Medical's Chief Medical Officer. I've been supporting the military, government, and industrial operations for the past 20 years. My professional certifications are board certification in preventive medicine, public health, and occupational environmental medicine. And it's a pleasure to be with you today.
Oh, thank you. He probably doesn't give himself enough credit, and I'll just kind of speak this. For those of you who have been around, he was a visionary for us. I mean, he really was there from the very beginning and helped with so much of the understanding of syndromic screening and things like that for COVID. So thank you, Dr. Cherry, for all it is that you do. We really appreciate you. All right, Dara Lou, how about you?
Yeah, I agree. Thank you, Holly. And we've been very happy to have Scott here and working closely together. So my name is Dara Wheeler. I'm Axiom's Chief Marketing Officer, and I've been with Axiom for 15 years, supporting these large-scale employee health programs. And I'm, those of you that have heard, I'm very, very passionate about it and happy to continue the conversation today. Thank you, Holly.
She's another one that probably doesn't toot her horn enough as well. She's a boss. I've been with her for over 10 years, and she's amazing. All right, guys, well, let's hop into what's going on because we have a lot to discuss. So basically what we'll be covering today, just kind of giving an idea of where we're going. So we're going to talk about the new data. We're going to talk about the variant, why it is that we're seeing this surge of cases everywhere, where some of those hotspots are. Then we will talk about Omicron, and specifically, we'll talk about some of the biggest threats, which those typically kind of reside around the area of education, complacency, the fear tactics aren't working anymore. We'll circle back around to whether a lockdown may be looming, and then we'll finish it out with the 3P workplace safety strategy for protecting your workplace. So, and I'll just kind of tell you that's the plan, the preach, and the practice. So there's your 3 Ps, and we'll get into all of them individually. All right. Well, Dr. Cherry, do you want to kind of start us out and maybe talk us through what it is that we're looking at here and what these numbers mean?
Sure. This is kind of a classic epidemic curve where you're basically looking over time as your x-axis, and then cases are in your y-axis. And you can see since July, there's been kind of this steady, almost linear increase of cases up until about September, and then kind of this slow linear decrease. And seasonality and a host of factors can create kind of these rises or spikes, so to speak, in cases. And what's interesting is that here in the United States, different states, depending on their geography, their density of population, can have quick spikes, independent of other states. And we're also kind of now, after a couple of years of experience with COVID, realizing across the board that there is this seasonality in the winter months as behaviors tend to, people become indoor more often and maybe even more crowded. It's kind of well recognized that there's kind of this winter seasonality as well. But we have seen spikes, at least 3 across these 2-year periods. And I think that's a function of new variants that become more transmissible. And so I think that's kind of the topic for today's, what we'll be looking for potentially for Omicron. And so, we have cases here, and then you can also, I'm not sure if deaths are on there, but we also track deaths as well. And that's kind of a marker for severe disease, although there's still hospitalizations that are kind of this midpoint between just a case, which a lot of them can be mild, and then obviously severe with hospitalization and death.
Thank you. Yeah, great information. 2 things I wanted to ask you about that, though, Dr. Cherry. The first was, whenever we started the week, it was like we were talking and we were hearing some of the data that was coming out of the UK from some of the analysts there. Does it look like that we will follow in the same path as what we're seeing on some of the other global trends?
I do. Obviously, everyone's thinking about Omicron right now, and the epicenter for that is South Africa. So we'll review kind of this South African study that gives us good insight into their trajectory. But, the UK actually is having a pretty interesting experience. So South Africa pretty much is almost 100% taken over by the Omicron variant, and it has displaced Delta, which is a very impressive feat, and that shows the dominance by which Omicron could displace Delta, because Delta was very transmissible and a very dominant strain over the previous variants. So I think the UK is obviously, I call it our canary in the coal mine for the US, because their demographics are similar, although they are a much smaller geography. But we are seeing their case rates dramatically rise. And so, our epidemic curve here looks relatively flat, but we were predicting a spike for the winter independent of Omicron. And now with Omicron, I think we're going to see almost an explosion of cases over the next 4 to 8 weeks.
So such bad news. Here we are at the holidays. And the other thing I was going to ask you about was some of the hot spots. Does it look like that we're following in the same pattern of what we initially saw with COVID, with some of the areas like New York, seeing a higher transmissibility rate and increase of cases there?
Yeah, Omicron is slowly kind of coming over into the U.S. There's, cases pretty much across the U.S. now, but there's not a heavy footprint, but we are seeing them in the most well-traveled and most dense cities. And that makes sense from just kind of intuition and kind of the natural course of close contact is really the name of the game for your highest risk of exposure. Some of the studies have shown that, and we've known this from the beginning, that household exposures are the highest risk, but Omicron has 3 times the risk of a household secondary case from someone in your house, 3 times the risk of getting infected from the Delta experience. So we're talking about a very highly transmissible strain here.
Yeah, definitely. All right. So then I guess that actually kind of takes us directly into this discussion of the two variants. So talk us through what that, we throw out a lot of terms, and I'm not sure that everybody always understands what they are that we're referring to when you're talking about transmission and is there a difference in symptoms and is this more severe, et cetera. Talk us through that and explain maybe some on a basic level what we should be looking for here.
Yeah, so with regard to transmission, I think that's probably the best word because it kind of goes across the layman terminology, but still is effective in the medical community. A lot of times you'll hear of infectiousness, but it's really kind of transmission. So how easily is it transmitted from one person to another? And we've been alluding to it a little bit with just we're bracing for really a large just a huge spike in cases, but basically infectiousness or transmission it can be defined with several different metrics. One of the easiest ones to think about is called the reproductive number. And so studies can look at if someone's infected, how many people are they going to secondarily infect? And so I think we've heard of herd immunity, which is kind of this thought about if enough people are immune, then disease will not proliferate. And so that's effectively talking about a reproductive number less than 1. So for every infection, you're not going to infect another person. So less than 1 is really key. Delta probably had a reproductive number around 2 or so. So for every person infected, they're going to infect 2 others. So it can almost be this linear to kind of geometric kind of or exponential growth. But with, I think early estimates for Omicron is the reproductive number is 4. So you can really have a huge spike or mass exposure events with Omicron because one person can really create a lot of risk for others. And a study was shared to me this morning by a colleague that looked at lab testing and looking at the speed at which the virus infects and then reproduces in the upper respiratory cells. So this is a lab study. It's not real life. But it was looking at the virus's ability to reproduce in these biologic cells, and it's about 70 times as fast as what Delta would be doing. So that really gives us insight into why South Africa, really their whole population in a matter of a couple of weeks was overtaken by Omicron and displaced Delta. And so let me know if I need to address any other aspects about transmission, Holly. I know there was a bunch of information there.
Yeah. Well, I was seeing that there was also some questions that were coming through here. It looks like that maybe some of those are specific to both severity and also symptoms. I noticed Robert was asking about that he had seen something that was saying that maybe it was affecting the respiratory tract versus the lungs, and was asking, was that a trend that we're seeing as well? Do you want to speak to maybe some of the symptoms that may be a little bit different?
Yeah, and that study I referred to actually did note that although there is this huge reproductive or huge speed of reproduction in the cells, the actual damage to the cells was much less than Delta. And that does kind of correlate to what we're seeing on the ground in South Africa, where we're seeing huge amounts of cases, but the hospitals are not, there's a decoupling between cases and hospitalizations and deaths. There's been some guard to compare South Africa to other nations because South Africa is a relatively young nation, and so obviously advanced age is a vulnerable population. So, but what's very interesting is symptoms. So obviously we are thinking severity is less. So obviously shortness of breath and really decreased oxygenation seems to be not a major symptom of this or common symptom. But, for an upper respiratory infection, cough and kind of the classic upper respiratory symptoms like sneezing, coughing are not part of kind of the syndrome that you see with the Omicron variant. And so it's really kind of like a viral syndrome where you're feeling achy, fatigued, malaised. You can have body ache, sore throat, headache, things like that. But the classic upper respiratory symptoms otherwise aren't there. So, COVID in general has been very frustrating for me professionally because we've never been able to precisely weight symptoms to predict COVID. And so I think it's a very sneaky virus that way. And Omicron, this iteration continues down that path. And so, we have talked a little bit about severity, but specifically when we look at the South African study, it looks right now that the severity is quite low. And comparing South Africa's own experience with Delta, it looks like there's about a 1/10 the deaths per case rate that you see in Delta versus Omicron. So that's a really positive message here. I would say, though, that just from a societal implication, this is great news if this continues on in that trend with regard to severe disease. However, because of such high numbers of cases, I do worry about implications to population health, especially the clients that we support in critical infrastructure and other industries that really need their employees to be at work, whether it's, on the front lines serving the public, emergency response, et cetera. So I think really because of the high transmission rate, that's going to be the biggest, that's what I would almost call as a severity factor here. Although here we're meaning it from an individual perspective. And so really right now, the South African experience really has quite low hospitalizations and deaths, even compared to its Delta experience. So it's kind of this internal control that I think will be analogous to the UK and then ultimately to the US.
Yeah, definitely. Yeah, and the other thing I was going to ask if you would also address was, I think we saw in the news this week that caught my attention was I believe it was one of the universities that had tested their population and so many were asymptomatic. Do you feel like if that's going to be a trend that we could be dealing with here that could make that scenario, the transmission scenario, even worse if you have more that are asymptomatic, but yet they're spreading that and it's happening so quickly?
Yeah, that's the other huge personal professional frustration of mine is the large proportion of asymptomatics. And that's actually been relatively consistent across all the variants of COVID. Just my own thoughts on this is, if they are true infections, it does matter. But I do think, before Omicron at least, that the coughing, sneezing were the primary mechanisms that made people most contagious because those symptoms usually would correlate with the high-risk viral load in the upper respiratory tract. Mm-hmm. And so it's to be determined with Omicron because obviously the symptoms aren't there, but the infectiousness is really off the chart from what I've been seeing early on.
Yeah, definitely. Hey, I did see that came in from Scott, and he said Dr. Cherry mentioned a decoupling of transmission and severity. He said that he had heard that it is the normal life cycle of a virus is that it becomes more transmissible and then less severe. And so he was asking, is that the case? And if so, is this a positive sign? And how would that maybe impact some of the herd immunity?
Yeah, so in general, when you're looking at a virus that is going through kind of this iteration of variation through point mutations, and I think the more formal term would be a genetic drift, where you just have this slow changing of the genetic sequence kind of over time. Usually what happens is exactly with what I think that person's name was Scott also, but that's kind of the common knowledge in virology that these genetic drifts make the the virus much more contagious or infectious or higher transmission, but usually less severe. And I think that's going to be the case here. We had some discussions with the executive team probably a week ago with the concern about, with the Spanish flu, which is obviously not a coronavirus, but, you had, influenza before the Spanish flu, but then the Spanish flu was so much more deadly. But that wasn't the case here, where you had just this small genetic drift. Although Omicron has a fair amount of changes to its genetic code, but with the Spanish flu, it was really what we call a genetic shift. And so there's a huge change in the genetic code, and almost I wouldn't say a species change, but it's what we call a clade change, where that flu came from a different species of reservoir host. So because we have such really good sequencing now, I think we have really good thoughts that this isn't the case for the Omicron variant.
Good deal. Okay. Well, let's move on and then kind of talk about some of the vaccination status. This is a hot topic, obviously. We've seen everything from, promotion to who's fully vaccinated. When are we going to call it? Are we going to say that a booster is included in a full vaccination status? I was listening to that from the lady from the CDC yesterday. And talk to us about where we stand here. I mean, it does look like we're making some progress. Do you think it's enough?
That's tough. So in general, my big thoughts on kind of the current vaccine status is, fully vaccinated is probably hovering, and that's the definition of a 2-dose of a messenger RNA. And even now, really, you need a second dose for the adenovirus Johnson & Johnson. So that's probably hovering around 60%, give or take, depending on the state and, the area. What we're, in relation to Omicron, when we look at kind of vaccine escape, first off, there's studies that looked at how Omicron can evade just the antibodies from vaccination or natural immunity. And so sadly, Omicron is fairly evasive to antibodies that are against COVID before Omicron. And I think that's why there's this huge transmission rate. A lot of people potentially before Omicron could be exposed, potentially infected, but generate a quick antibody response and really prevent infection. But I think because of the genetic changes of the Omicron spike protein and actually the capsule or the capsid itself, I think it can evade the antibodies fairly well. I think the studies have estimated 20 to 40x less effectiveness in neutralizing activity for antibodies. And so when we think of how vaccine status or immune status, if you've been previously infected, and how Omicron interplays with that, Omicron has been able to degrade the protection from vaccination, just say a two series shot from messenger RNA down from, say, 80 to 90% down to 30%. So that's why you see our public health authorities and officials recommending a booster. When someone's getting that third shot, then their protection level goes up to about 70% on average. So I think that in general, the numbers we see here, we're vaccinated and boosted is only at 17%, partially vaccinated at 11%, not vaccinated over 20%, depending on their natural immune status as well. I mean, everyone is at fairly high risk for exposure and contracting infection based on that. And I think just Omicron is, it's been evolved to infect a lot of people,
Mhm. Definitely, yeah. I noticed that Robert had a good question. He had typed in, he was asking, given the severity of the virus seems to be dropping and the vaccines are leaky, why would we continue to mass vaccinate versus targeted vaccination of the vulnerable population?
You know, this kind of brings me back to like public policy. So public policy is really going to be a mix of several inputs, right? So obviously the medical science, the clinical practice, the availability of vaccines, the effectiveness of vaccines, but also kind of it's a political discussion and compromise. So I know that this could be fairly contentious in many ways, but I think the ideas and potential suggestions there aren't unreasonable, but it's really a mix of a kind of a compromise between politics, and the medical science in many ways, and people's values or perceptions of risk as well. So it can be very difficult to come up with a policy across such a large nation.
Yeah. It looks like we've got a lot of questions all of a sudden that came in about boosters, and I think we could probably maybe wrap this up on this section, but there are a lot of questions of, if you've had both vaccinations, but yet, the CDC is saying that your next move is that you really need to get your booster. Does that mean then that you are protected, or, and how does this impact children as well? I think Lindsay had asked about, or maybe no, I can't remember which one it was. No, it was Lindsay that was asking about the kids. Are they no longer protected if they're not given the third booster? Do you have any thoughts about this? I realize it's really new and there's a lot of data that we'll still need to dig into, but it does seem that the messaging that's coming out of the CDC is very proactive in terms of promoting this booster.
So in my role at Axiom, when I'm advising clients for large population health policies and programmatic architecture, it's the way I look through it is, what does a certain intervention give a client with regard to that population? And so say you were to boost with the current understandings with the protection from a fully vaccinated and boosted population, you have about 70% coverage. So if you have 100,000 employees that were fully vaccinated and boosted, 30% would still be at risk for getting symptomatic infection. And so that helps kind of business leaders decide how to move forward with that, putting emphasis on vaccination or the other components of the multi-layered approach, which I think we really need to spend some time on today is, actually kind of digging into that as well. But so say you have 100,000 workforce, 70,000 would be protected from symptomatic infection, but 30,000 wouldn't. So do you need to do other aspects from this multi-layered approach,
Yeah, definitely. And it looks like we had some additionals that came in, but I think we can wrap those up in some of the slides that are coming up. But I did want to spend some time, we'd put out some polls as well. And whenever we look at the threat that really exists, not just in the public, but also in the workplace as well, it's like you can sense, everybody's exhausted. It feels like this Groundhog Day, like we're doing it yet again. We're going through the same scenario yet again. And all of these things, the tactics or the way that we presented and communicated before, it doesn't seem like it's having the same type of effect. Is that the case? And how do we get past that to be able to get people the new information that's needed to be able to take care of themselves and their workplace, their families, everyone?
Yeah, no, this is a great discussion. It's interesting here, the statistics that are kind of compiled. And so, it looks like a large, more than half of the people polled feel like we're not being told everything we know about Omicron. And so part of that is we don't know a lot about Omicron yet, although we are gaining a significant amount. But I do think in general, the public, there's a lot of skepticism or hesitancy. A lot of the public health messaging has changed over time, or maybe even reversed on itself. And, that's really difficult to undo or try to heal, so to speak. But I also think what you talked about, there's so much information out there that it's really hard to understand what to really focus on. And so you almost, although there's so much information out there and you have access to it, you almost need an expert to guide you through all that information. I'm kind of pushed to my limits, so I reach out to other specialists in my field or in other fields to kind of help me get the best framework for how I think about different components. And so I think employers should do the same. I mean, you can obviously Google things and read the news, but you're pretty much overwhelmed immediately. And so having kind of this expert to guide you through it is probably a key component of your best way to navigate. It's kind of that information versus wisdom, which is kind of that experience component. A lot of studies are, quoted in the news, but I would say they're kind of diluted from a value perspective because sometimes the headline just takes the quick finding, but doesn't understand the limitations of the study or even look at the statistical analysis. There's just a ton to deal with, but I think the take home, what we're seeing is there's not a lot of credibility given right now to what's being put out. And so eventually that is leading to a lack of public education, distrust. And I do think there has been a fair amount of fear that's been tied with the media coverage. And, I think that may be purposefully because fear is much more impactful versus optimism. Obviously, with a pandemic, it's, to be expected to some degree. But I think if we could share more plain facts and help people kind of give them information to, intake and then make decisions for themselves on an individual basis. And then obviously for employers at the population level. And just based on time, complacency is always a factor in any safety sensitive role. And so, many safety sensitive employers deal with this all the time outside of COVID. And so how do you now almost every employer is a safety sensitive manager or kind of in the safety sensitive category, so to speak. So I think if
I'm
we
always
could
thankful we have. I'm sorry.
Yeah.
Go ahead, Scott.
Just my last thing is, if it's really about trying to get actionable, very poignant information to those business leaders and to individuals, because ultimately it's each employee that has to have buy-in. So you almost need a bottom up and top down approach kind of synergistically.
Absolutely. Dara?
Yeah, I was just saying I'm thankful we have our own Dr. Cherry to run all of the studies and news articles by, because even internally as a group that looks at this day in and day out, it is hard to weed through the noise. And we rely very heavily on our own experts like Dr. Cherry to make sure that we're looking at things correctly and not either jumping to fear and conclusions and vice versa, that we're not underestimating the impact of something. So just wanted to say thank you.
For sure.
Thanks for that.
Yeah. So, this kind of brings us to where we started this conversation, was this issue of lockdown. And I think that definitely puts a fear in every business leader at this point is, what if we ended up back in that scenario? And, in the beginning of the week, it was like no, we would never have this. But then you saw the UK data that came out that said, hey, if we don't get a hold of this, then we may need to go to some of these levels. And then we saw a lot of news that was coming up this week, and especially within the last 2 days, about all of the other organizations that have had, outbreaks. We're seeing Trivago that's having, they're seeing cancellations of their holiday plans of people. You've got the outbreaks in professional sports. People are discontinuing plans for their holiday parties. What do you read into this? Do you feel like that it's time to maybe take a more proactive approach and take a little bit more precautions early on, or what would you advise, Dr. Cherry?
So if you can get a sense of if you're, in your region, what's the primary driver for a lockdown? Is it cases? Is it hospitalizations? Is it deaths? I think it's not clear to me if there's a consistent trigger, so to speak. I know cases early on were the biggest focus, and you would hear, oh, there was, early on, here's a case, and I think now we realize there's going to be cases all the time, and so is it what percentage of cases? So for instance, one of the primary metrics I track is what we call test positive rates. So what percentage of tests, if someone was to get a test, are positive? So just to give you some perspective, with other outbreaks where there were surges in different regions that I was supporting, 10 to 15% test positive rate is a very high rate. For some of our special populations that we do very close monitoring and medical surveillance with, very frequent testing and that multi-layered approach, we actually suppress test positive rate to 0.3%. So the test positive rate in South Africa kind of in the last week has been about 33%. So you're talking about off the chart test positive rate. So
wow.
So if you're in a region that is going to just shut down based on cases, that I think is going to happen. If it's based on hospitalization utilization or deaths, then, I think there's going to be more nuanced where it may not happen. So I think it's trying to get a sense. So if you have a local public health department, if you have organizations that can get a hold of the mayor's office, the governor's office, to get an understanding of what are those triggers. So that's just to kind of understand what's the criteria by which your company will be judged. But, from my perspective, is trying to really minimize. I've always said, and we want our clients' workplace to be the last place the epidemic to hit, right? And so let the outbreaks be in the other areas, so to speak. And so we are very conservative with our Axiom standard with regard to kind of our multi-layered approach. And but I understand that you need to have it is a business decision and about how protective or how much energy and resources you put into protection, because we're going on well over 2 years now. So it's trying to show the biggest value for each measure. And so that's why we can explain kind of, what does vaccination buy you? What does masking buy you? What does, hygiene buy you? What I think is very important, and we may talk about it later too, is, we created, and thank you, Holly, for the kind words at the beginning, but, when we decided to make a COVID screening service, 2+ years ago, it was an old school kind of military syndromic surveillance, so just screening for symptoms. And me and Dara kind of always have been hopeful during this pandemic that every time we got testing or vaccination or, some other really some technological assistance, that this was going to help us have 100% certainty over our old school protocol or application. But I think even now more than ever, syndromic surveillance or just screening for symptoms is absolutely critical, because you do not want someone sick coming into the workplace, you know?
Absolutely. Yeah. And, you know, I will maybe interject this here, is that, you know, you did see that there was some news. There was a news story that came out this week on one of the organizations that had, you know, came out and said that, okay, if our employees aren't going to get vaccinated, then A, they can't use their sick time, and B, they're going to pay $50 more a month on the insurance. And, you know, it's like, it's a hard discussion. It's a hard conversation. It's a lot to take in, because it's like, you know, on one hand, you understand their goal of wanting to drive that forward to make it a safe workplace. But at the same time, you know, whenever you're looking at the different at frontline workers that are working on hourly salaries, that, you know, they live paycheck to paycheck. If you make some of these hard, fast rules, will that impact what that behavior is? I mean, that's really been one of the biggest drivers, and you've said it since day one, is that we've got to change this culture that we've developed within our workplaces, of that people are coming to work sick, that it's okay, because that's what keeps us in this mess.
Mm-hmm. Yeah, you know, that example you bring up, it's difficult. You know, I would say, you know, obviously it was a business decision, and so there's multiple factors besides the medical science that go into that. But, you know, our current understanding of a fully vaccinated and boosted population, there's still a 30% risk of getting infection. And so, you know, you need other approaches besides a vaccination policy to really protect at maximum, you know. And so I know businesses are kind of making really tough choices about kind of medicine, right? And whether it's their health insurance policies, their personnel policies with regard to, you know, vacation and all that. So it's really tough, you know.
Mm-hmm, for sure. You know, and what we kind of talked about with these 3 Ps, and it seems so simple, but, you know, just knowing what's going on, planning, preparing, and then, you know, just preaching and also practicing. I mean, what advice would you have, or Daryl, what have you been hearing in terms of maybe practices that people are putting in place to make for sure that once there's a decision made, that these things are followed up on, that everybody's following the same rules, that, you know, you're not getting complacent, that we're all, you know, whether it be checking in daily or whether it's, you know, screening for things. What are your thoughts here?
Yeah, I'll start and let Dr. Cherry have a minor break, since he's been talking so much. Yeah. I think we're in an interesting situation right now where most of our clients have been very, very focused on the OSHA ETS and the pending regulation. And I think that when we talk to clients, and Dr. Cherry and I talk to a lot of organizations, and when we talk about these kind of 2 different buckets of compliance versus health in the workplace, and I think everybody's spent a lot of energy focusing on compliance versus health lately, because we were in a more stable realm with Delta, and we were kind of just going through these motions of trying to understand compliance and how would we manage a compliance program. And then now all of a sudden, very quickly, we've had to switch gears again, which, you know, welcome to the last 2 years of all of our lives. And I think that now we're back to health and safety in the workplace, which, you know, Dr. Cherry said, those organizations that have historically been in safety sensitive, fit for duty type organizations and programs are very used to engaging in this type of preparation, planning, practicing, and communication plans, where they understand human nature is very likely to become very complacent. They kind of just, everybody gets used to the way we do things, and that's when injuries occur, that's when outbreaks occur. And those clients that are on this call that have been with us since the beginning are probably getting really tired of me talking about these layered approaches, but we talk about them because they work. And I know I've seen a few questions come through from the audience that say, am I 100% protected? And I do think, you know, let's say I'm vaccinated, and let's say I wear my mask every day, and I've gotten my flu vaccine. Am I going to get sick this season? And I think the biggest answer is that these layers will reduce your risk, but risk won't be zero. And so if we don't put these layers in place and we just rely on one, if you just rely on vaccines or you just rely on testing, then yeah, your risk is relatively high. But if you think about the layers and stacking one on top of the other, then that's how, as an organization, as a company, and then as a public, we're going to reduce the risks of illness and severe health situations. So when we talk about, from a traditional safety perspective, cleaning and safety controls, contagious illness assessments, that's what Dr. Cherry and Holly were both talking about, where we still need to understand if somebody's symptomatic, do not come to work. And let's make sure we've got programs in place that if you're symptomatic, you don't come to work. And that is so ingrained in us and as Americans to keep working through things. And even though a lot of us still work from home and haven't fully returned to the office, I still think there's an argument for making sure that you're fully present when you work, because that we all have really tough jobs and it's hard, and being sick, it's very difficult to work when you're ill. And PPE, I know Dr. Cherry mentioned, we've talked briefly about mask wearing. Because of the transmissibility of Omicron, mask wearing, it can help, but it has to be KN95s or N95s. And so some states have now gone back to some mask mandates, but it has to be very specific masks. And in the workplace, if we think about mask wearing, we need to make sure we're wearing the right masks. The daily health attestations, contact tracing. Contact tracing is going to be interesting with Omicron, because if we're looking at a rate of 4 times what we've seen before from a transmissibility standpoint, then that's going to be really tough. But yeah, making sure that we isolate people that are ill and not transmitting in the workplace, and creating an outbreak, like Dr. Cherry said, where we're shutting down stores, shutting down locations, which would be a huge impact to businesses. Simple things like hand hygiene. I don't think I've ever washed my hands as much as I have in the last 2 years, but going back to those simple practices, it's important. And those of us that have kids know how hard it is to get a 2-year-old to wash their hands on a regular basis, but it's important. And then the top 2, and the reason vaccination and testing are on those top 2 layers is they are critical, but they are not your only layer. You have to include these other pieces to protect our teams and our workforces. So that's my soapbox. Scott, anything else?
I think when you brought up the ETS, I know that's been such a big, it's a big issue, right? And right now we're kind of paused, and we've been talking with our clients about, aside from kind of a requirement from OSHA, I've seen companies actually go above and beyond an OSHA, an existing OSHA standard, because they have their own inside or consultative information that pushes them to do more. But I think Omicron is actually a perfect pressure test for the ETS. And so obviously we haven't gotten information back yet on the ETS, but we've seen companies get shut down because of too many cases. And so would the OSHA ETS actually prevent that or not? Or should you go, maybe instead of just meeting that standard, go above and beyond to preserve your operations? It's a delicate assessment, but I think having those discussions are absolutely critical, because, say you do move forward with complying with the OSHA ETS, but then still have an outbreak because you're only relying on weekly testing or vaccination, which, as you can already tell from our discussion today, it's not going to be 100% coverage. So, I think what's very interesting is the OSHA ETS doesn't have daily health attestations as a requirement, but I think that may be one of the most important components of best practice. And so, again, I think it's about, you have to comply if it comes with enforcement issues, but really it's about preserving your operations on one side, and it's also doing the right thing for your people on the other side. So it's really potentially a win-win-win. Obviously, the budgeting perspective needs to be incorporated with that planning,
Yeah, absolutely. Well, I think we do have some additional questions. We've taken some as they came through. I hope that y'all give us some feedback if you like that format of actually kind of taking that. Some of the questions you're submitting and putting those in at the same time, or whether you prefer the alternative route of taking them at the end. We're always interested in your feedback there. We just have a few town hall questions that were here, and I think that they mirror some that were listed in the chat as well. But the first was, will boosters be included for a fully vaccinated status? I think we kind of briefly talked on that. Looked like that the CDC gave a really loose answer yesterday when asked specifically. Anything else you want to add to that, Dr. Cherry?
You know, it's unclear to me, you know, even before Omicron, when I saw that there was waning immunity from vaccination, my gut was, you know, along the lines of what we've seen from kind of the politics and the public policy on this. I would thought for sure they were going to make it required, but it's to be determined. So I'm not sure.
Okay. All right. Good deal. Next one, I think, was, Randy was talking about, so would you recommend testing then if you've got employees that are out and they are traveling for the holidays during this time period? Would you recommend that they are tested before they come back to work?
I do actually. We've actually had some really good, we've had a couple years experience now doing this. And before it was just a theoretical recommendation, but what we've seen is there's this bulk of test positives that, you know, when people are out and especially doing high risk activity like, you know, traveling for the holidays, close contact with more people than usual, it's going to buy you a ton of secondary exposure preventions, you know, getting people back, getting people tested before they come back to work. You know, obviously you can go down the path of medical surveillance testing ongoing, but I think if anything, just that one-time test buys you a lot, you know.
Mm-hmm. Mm-hmm. You know, there's that Robert also had written in here, and he had mentioned that not going to work whenever you're sick is not an option for all workers. And you are so right, Robert. You are so right. And I think that's maybe why I've been on this soapbox as well this week. It's, you know, it's like everybody is struggling right now. And, you know, people live paycheck to paycheck, and it's tough. And to say then that, you know, you can come to work or you can't come to work, you know, we as a nation, we need to come up with some better strategies to address this. So you're exactly right, Robert. I appreciate you saying that, and we agree.
Yeah,
completely.
and I think that Holly, when you mentioned some examples in the news recently, that's where employer policies and practices become so critical. And like Dr. Cherry said, sometimes employers are making business decisions, but not necessarily thinking about some unintended consequences. And one of the unintended consequences we've seen is people coming to work sick and getting the public sick or getting other people sick because they have to make a paycheck. So there's a lot to unpack there, and I think that we've learned a lot of lessons as a nation, but that complacency, we are, as humans, like to move on to the next thing, and sometimes don't always learn those lessons fully.
Mm-hmm. Hey, I see a comment in here from Mr. Les Curte. He is one of our other physicians that's new. He said, recent information about how to effectively communicate is that fear is not working well. The best strategy to deliver the facts as best as we know them. Great job following that best practice. So thank you for that input that you shared there. If you guys haven't met him before, we've had him on several different times, but you will see a lot of him coming soon, because mental health is a big focus for us for this next year, and he's brilliant. He really will be a great guide for that. All right, let's see a few more questions. Karen, can you explain why Delta and Omicron together could be more dangerous, and will winter also be a factor?
You know, so obviously we're kind of in this hybrid right now. I think Delta is still the dominant variant in circulation. So we know Delta, our current knowledge is it's more severe. So, you know, I guess kind of intuiting your question, Karen, you know, you could have kind of this mix of a fair amount of severe disease and then a ton of just cases. And say Omicron just becomes the dominant variant overnight, we're expecting such high case levels, although on average it's going to be less severe. Based on it just being a much higher number of cases, you're still going to see a fair amount of severe disease. I know it maybe sounds, say for instance, with Delta, 5% of infections go into the hospital. Say Omicron is half as infectious, but causes 4 times the number of cases. You still may have kind of at least the same number of hospitalizations or more, just based on a higher case number. And so I think that maybe that's where Karen's getting at. So and then winter, obviously seasonality, we were expecting just kind of higher cases in general to manage because of winter seasonality.
Scott, I also saw a news flash recently about more flu cases already too. Yes. So I wasn't sure if you've been tracking any of that as well.
That I did not see, but I remember you were talking about you've washed your hands more often than not, and I think with COVID, it's been unclear kind of the fomite, the kind of the tabletop, the doorknobs, like the contribution of infections. But, as we think about just all infectious disease in the workplace, there's some seriously high transmissible infections that really can be really prevented by hand washing, like RSV. And so whether it's COVID, RSV, flu, strep, that potentially can affect your workforce, good hand hygiene is going to prevent most of them regardless of the specific disease. So that had just popped in my mind from your discussion about hand washing.
And as soon as you say that, I start wanting to touch my nose and itch it. So.
Yeah. All right.
Your power of suggestion. Sorry, go ahead, Holly.
All right, 2 more. If we can be fast, I got to be brief. Okay, let's see. We also had Pamela that was asking, is there a particular time frame for when we think that we're going to see the highest number of cases? Really good question.
Yes, that I feel pretty good about. Once Omicron becomes the dominant variant, I think we're going to expect the peak by week 4 from that. And whereas with Delta and the other variants, it was 8 weeks, but we've seen in South Africa that it's about a 3 to 4 week peak. So.
Okay. All right. And then, then maybe then for us to anticipate, you're saying then, to be clear, we're thinking that we would be looking at
once it's the dominant variant. And right now it's not yet. So even in our own lab data, we're not seeing it take over Delta yet. But as cases are coming out in these various states and populations, because of the transmissibility, and I'm interpreting all this from what Scott said, that will start to spread very quickly once it becomes dominant. And when we test variant and we sequence these variants, and that becomes and takes over Delta 4 weeks from that date.
Yeah.
Does that make sense, Holly?
It does, absolutely. All right, last question. This one was actually from Michael, and he had a really good question. He said, when do we expect to have clear guidance then on when or if the ETS will be in effect, as well as CDC, state health services guidelines and guidance? Good question.
I thought we were already going to know something, but I'm just wanting to know. That's why. But Dara, do you remember if Chuck has said anything in addition?
He said hopefully by Christmas.
Oh,
but
wow.
I thought we would have some info by last week. So trying to guess this timeline has been really iffy. We're still developing all of our solutions to be delivered by January 4th and these dates that we're supposed to hit for OSHA. But our Chief Legal Officer, Chuck Cable, has said that he expects by December 25th to have at least some information.
Good deal. Good deal. I saw that somebody had asked about, we have put this guide that's there in the resource section. They said they were asking how could they access that. If you'll go there to the resource section, that'll give you the link. And in the event that you do not receive that, whenever you click the link, if you want to just send us a message or actually we can just pull your question up. We will follow up with you individually as well. So, guys, I think we're kind of at the end here. We did start a new series. I removed actually the date for this on when we're going to have our next one because I have a feeling that we may be dealing with an issue. We may have an issue. We have a lot of things that are priority whenever within the next few weeks. Send out some more information, but up next on deck will be Dr. Curtay, and he's going to be addressing a lot of the mental health matters and kind of the trends that you're going to be seeing for this next year. Any final thoughts before we sign off for 2021, Dr. Cherry and Dira?
So I'm going to go back to kind of my med school days where you go through all this information, but at the end of a chapter, you just I just need to know these 3 things, but I'm going to just do one thing, and it's syndromic surveillance. Monitor yourself and your workforce for symptoms and do not come into work if sick. I know, Robert, you talked about that may not apply to all jobs, but if you are in a job that does have paid time off or short-term disability, we would at least like to see it happen in those realms because I don't think it's happening in those realms. But I think it's a bigger discussion for society at large. But I want that to be a take-home for today.
Absolutely. How about you, Dara?
I'm just going to say, leading into this fun holiday time, everybody stay healthy and safe and keep those layers going and stay protected. We appreciate all of you. Thank you.
Absolutely. Yes, absolutely. All right, guys. Well, happy holidays. I hope you all have a safe and happy holiday season. And we look forward to seeing you in 2022. Bye-bye.